Welcome everyone to this month's BJJ podcast. I am Andrew Duckworth and a warm welcome to our podcast for the month of November from the Bone and Joint Journal. It is now a year since our very first podcast, and from all the team we would like to thank our readers and listeners for the comments and support we've received so far for our series, as well as to our many authors and guest interviewers who have taken part so far. In the past year we've covered a range of topics and we've heard from a range of authors from across the globe. We've spoken to guests all the way from the US to India, including a fascinating dialogue between Ian Murray and Dr. Scott Rodeo on cell therapies and orthopedic surgery, as well as a really excellent discussion between Sam Patton and Professor AJ Puri from Mumbai about his paper on neoadjuvant denosumab in giant cell tumours. Through this, along with a series of podcasts that accompanied our supplements for the American Hip and Knee Society closed meetings, we do hope these are improving the accessibility and visibilities of the studies we publish for both you as our readers, as well as for our many authors. So moving on to this month's study, as you know, over the next 15 to 20 minutes so, we'll cover a range of topics and aspects of the chosen work, emphasizing the important points of how the study's been designed, as well as the key findings from the data and how these potentially fit into each of your day-to-day practices. We also hope to give you a behind-the-scenes insight into how the authors have developed the study and give them an opportunity to put forward the key findings of their work. So today, I have the absolute pleasure of being joined by one of my editorial board colleagues here at the BJJ, Dr. Matt Abdel, who joins us from the world-renowned Mayo Clinic in Rochester, USA, to discuss his study entitled Reliable Outcomes and Survivorship of Primary Total Knee Arthroplasty for Osteonecrosis of the Knee, which will be published in the November edition of the BJJ. Welcome, Matt, and a big thank you for taking the time to join us today.
Well, Andrew, thank you for the warm welcome, and thank you to the Journal for allowing us the opportunity to do this podcast on our article. It's exciting, and I do think these podcasts provide a large amount of information accessibility to the readership and actually the larger orthopedic audience.
Thanks very much, Matt. That's really, really good to hear. So if we move straight onto your paper, Matt, as you nicely describe, knee osteonecrosis develops from a disrupted vascular supply causing periarticular bone and cartilage loss, which in the advanced stages may lead to joint degeneration and destruction. And you state that total knee replacement or arthroplasty for this condition has traditionally been associated with likely suboptimal results. So with this in mind, can you give us a brief background to the paper, and in particular what we know from the current literature about the role of TKA for this condition?
Yeah, you've highlighted some of the main points nicely, Andrew. We know that knee osteonecrosis in both primary and secondary situations can lead to degenerative joint disease. And this can be profound for patients. It can have debilitating pain, inability to ambulate, and exponential increase in their degeneration. Typically, total knee arthroplasty has been associated with poor results, and those are results in regards to survivorship, high rates of aseptic loosening, poor clinical outcomes, and a high rate of complications, namely periprosthetic joint infection and manipulation under anesthesia. And we asked in our study, with contemporary knee arthroplasty, including the adjuvant use of metaphyseal fixation such as cones, or even some proximal diaphyseal engaging cemented stems, would the results be better in three main areas? That is survivorship, primarily free of aseptic loosening, free of any revision, and free of any reoperation. Clinical outcomes, namely knee society scores, because that's what we capture the Mayo Clinic Total Joint Registry longitudinally since the inception really of the registry. Mm-hmm. And how were the radiologic results? And that was kind of the impetus to the study that we moved forward with.
That's great, Matt. And I think that's a nice way to explain the sort of potential holes in the literature and how this study was going to add to it and the primary aims of it. So if we move on to the study itself, this was obviously a retrospective review of all patients who underwent a primary TKA for knee osteonecrosis at your institution over a 10-year period. And that was from 2004 to 2014. You initially identified 173 knee replacements in 161 patients for primary or secondary knee osteonecrosis. And that comprised just over 1%, amazingly, of the primary TKAs performed at your institution over this time period of the study. So with that in mind, obviously it's a large volume center, Matt. Could you just give us like a brief overview of the routine assessment you've alluded to already, the follow-up assessment of these type of patients in your institution?
Yeah, you've highlighted some of the big points. Just to reiterate, this is a small patient population. This is 1% of all primary total knee arthroplasties done at the Mayo Clinic. And this is total knee arthroplasty. We've independently published on unicompartmental knee arthroplasty for osteonecrosis. So this is truly primary total knee arthroplasties for osteonecrosis. But 2/3 of these patients were primary osteonecrosis and about 1/3 were secondary osteonecrosis, mostly steroid-induced versus idiopathic. And our follow-up routine is we see people, we call them at 2 and 5 weeks via the phone. We see them at 3 months, 1 year, 2 year, 5 years, and every 5 years thereafter. And so the capture is robust. And when we're seeing these patients in follow-up, we're obtaining clinical outcome scores, radiographs, and of course, having their clinical follow-up. So we have a large amount of information and a great capture for these patients.
Yeah, that's amazing, Matt. And I think in terms of the fact that you're seeing them, not just sending out outcomes scores or whatever, you're actually seeing those data, those time points is amazing. And in terms of sort of related to that, I suppose, what for this study itself, what was your follow-up like and retention like for the patients?
Yeah, so, there were some people that were lost to follow-up secondary to death. There were some patients that had early re-revisions or reoperations, less than 2 years. But greater than 90% of the patients had greater than 2 years of follow-up and were living greater than 2 years. So that's kind of my cutoff as follow-up. So we had excellent follow-up in this cohort. Yeah,
definitely. I completely agree. And in terms of, if we move on to sort of the I suppose the technique and the indications itself, what were those over the study period? I suppose, and what would also be important to discuss with the sort of the implants and the protocol used during the study period?
That's a great question, Andrew. So we treat these patients for regards to indications just like any other knee arthroplasty patient. They have to have failed conservative management, debilitating daily pain that is impacting their activities of daily living. And so that's very important to us. I will make a side note that most of these diagnoses were made on radiographs, not advanced imaging. That's something that often comes up when we discuss this paper. And once patients have truly failed conservative management, we then proceeded with total knee arthroplasty. Our routine at the Mayo Clinic during this time period and continues to this date is primary posterior stabilized total knee arthroplasty. That's cemented, which 88% of patients in this series received, so the vast majority. Our workflow is traditionally, and as you might anticipate in North America, to resurface the patella. So the large number of patients in this series had their patella resurfaced. And then the nuanced part of this was whether or not fixation was utilized with a cemented stem. And that was utilized on a case-by-case basis, the decision made by the operative surgeon. And I can tell you my personal workflow is not to use a tourniquet in these cases, evaluate the bone, see if the cancellous bone is bleeding. If it is, and I feel like I've got robust bone quality in addition to quantity, I may not use a stem. If there's any concern at all comes into my mind, I will utilize a short stem, usually something that's anywhere from 50 to 100 millimeters.
Okay. That's brilliant, Matt. And I think that's very clear in terms of the indications of the patients you've included. Just briefly going back to that point, Matt, in terms of you said, just to clarify, not many of these patients had MRIs. Is that right? It wasn't routine for them all to have them.
Yeah, so it's very rare. In fact, it was a diagnosis made on radiographs. And I think we can't forget that the series spanned a large time span, including a span in which MRI, even CT, was not commonly utilized in practice. And so we've utilized it since our indication was degenerative joint disease secondary to osteonecrosis. We still made most of the diagnosis for knee arthroplasty based on radiographs.
Absolutely, that makes total sense. So, if we go into just before we get onto the results, I suppose one of the it's always just good for our listeners just to briefly lay out the analysis you performed, which I suppose is really related to the regression analysis. Could you just talk about that briefly, Matt?
Yeah, we used two main analyses here. The first one was a Kaplan-Meier survivorship. And really, you could use a Kaplan-Meier survivorship curve, or we could utilize a competing risk, with the competing risk being death. So many of these patients survived, and so we didn't feel that it would be beneficial to have a competing risk analysis. So we utilized Kaplan-Meier survivorship curve, looking at survivorship free from aseptic loosening, survivorship free from any revision, and survivorship free from any reoperation. Yeah. Then we did a Cox regression analysis, excuse me, and that was helpful for us to look at hazard ratios and look at possible factors that might indicate failure. And we'll talk about that in the results section, but those were the two main analyses we utilized in the series.
That's great, man. That's a really nice summary. So if we'd move on to the results then, so to just reiterate to our listeners, I know we're repeating ourselves a bit here, but just there were 156 patients, of which 167 had TKAs in the analysis. The mean follow-up from surgery was 6 years. The range was 2 to 12, so very good. And again, the main outcomes that you mentioned earlier, survivorship free from aseptic loosening, revision, or reoperation. The second being complications, and then finally it was clinical and radiological outcomes. So Matt, if you can just detail the kind of findings, I suppose in probably the key one really in relation to survivorship and what those analyses show when looking for risk factors for failure.
Yeah, that's very well summarized as always, Andrew. So I think like you said, we had three main buckets: survivorship, clinical outcomes, and radiologic outcomes. And the key one to the surgical audience who we're talking to today is survivorship free of aseptic loosening. And this is traditionally the outcome that had done poor in other series. And we looked at survivorship free of aseptic loosening at 10 years. So this is not short-term follow-up. This is a decade. And that's when I kind of, in my mind, consider that beginning to be long-term follow-up. And that survivorship free of aseptic loosening at 10 years was remarkable. It was 97%. So, I mean, those are numbers that compete with the most routine run-of-the-mill osteoarthritis with excellent implants and excellent surgeons.
Absolutely.
We then secondarily looked at 10-year survivorship free of any revision. Now, that's important because any revision, of course, includes periprosthetic joint infection, for instance, because you have implant removal. And that was 93%. And as I alluded to, there is the usual 1 or 2% of infection that occur. And that's why that rate's a little lower than free of aseptic loosening. And then we looked at survivorship free of any reoperation, which I personally think is important because any reoperation includes anytime you open up the knee, but you may not exchange implants, i.e. wound dehiscence, stitch abscesses, things of this nature. And that was 82%. So lower, but we can't forget that most of those reoperations are quite minor. Yeah. The take home here is that the survivorship free of aseptic loosening at 10 years was 97%.
Which is, like you say, it's remarkably comparable to just routine joint arthroplasty, as you say. So, but with regards to the complication profile in these patients, Matt, did you find anything different there, or anything untowards?
You know, I think, Andrew, the thing that popped out to me to just kind of go directly, if someone's listening to this and they're going to be taking care of a patient, is they had a higher than expected manipulation under anesthesia rate. That was the main complication that came out with this. And when I define complication, I define it as something that wasn't a reoperation, revision, or loosening above. And so that rate was almost 4 to 5%. And so it's important to be cognizant about surgical technique, component positioning, implant design, but most importantly, be cognizant in how you counsel your patients and how you postoperatively manage these patients. So this is a subset of patients that I'll see more frequently to ensure that their motion is on track.
Mm-hmm. Yeah, that's interesting. And do you think that, Matt, is that because you think it's related to the primary condition, I suppose, or are these patients slightly younger, or is there anything in particular you feel from either from the data or from your practice about that, why that is?
I think it's threefold. I think one, in general, this is a younger patient population. We know that's a higher risk for manipulation under anesthesia. Number two, I do think there's something with the pathologic process and the pathogenesis of osteonecrosis that impacts the synovial membrane in addition to the chemokines and cytokines that arrive in the knee that may contribute to it. And I think finally, a lot of these patients are so debilitated that the periknee musculature becomes quite contracted, that it just takes a little more time to loosen up the soft tissue envelope, if I may say it that way, surrounding the knee after the arthroplasty is done.
Yeah, that makes sense. That really makes sense. That's interesting. And just before we actually move on from onto the sort of clinical and radiological outcomes, was there any factors you did find in terms of that were increased risk of revision?
It was interesting. We went through an extensive analysis using the Cox regression analysis and did not find any real significant factors that predicted failure. And that's probably because it's rather homogeneous population of individuals that develop this very nuanced and quite unique pathologic process of primary or secondary osteonecrosis.
That's interesting. So
I think, Andrew, I think you know what happens is that the process of osteonecrosis overpowers any other factor that we were unable to see other factors as contributing to failure.
Yeah, it just overwhelms everything else, you mean? Yeah, absolutely. Yeah. But just to clarify though, you didn't find a difference between primary versus secondary though, did you either? That was part of the analysis. That's correct.
That's a great question. Yeah. So we did look at that. Now we have to keep in mind that 2/3 of the patients were primary, 1/3 were secondary osteonecrosis. And within the secondary osteonecrosis, there were a variety of etiologies that contributed to that. But you're right. In regards to survivorship, we found no difference at all between those patients that had a need for primary versus those had a total knee for secondary osteonecrosis.
That's interesting. Well, we can obviously come on to that in a bit when we discuss why that is and how that compares to literature. But just before we move on to that, I suppose, is what did you find in terms of, I suppose, the clinical outcomes and the knee side scores and the radiological outcomes finally, Matt?
Yeah, for knee society scores, we found that patients went from a mean of 57 preoperative to 91 postoperative, both in themselves impressive numbers, very low pre-op and very high in the 90s post-op. And that's at most recent follow-up, and that was statistically significant. I would also say that's clinically significant, a jump like that of nearly 40 points.
Definitely.
And at most recent follow-up, we had no radiographic evidence of loosening in any patient that had yet to be revised. So there were no impending failures based upon radiographic criteria of impending loosening.
The last follow-up, that's interesting. So that's great, Matt. So if we sort of move on, I suppose, to the implications of the work, Matt, the strengths are, I think without question, it's a large contemporary study of cemented TKA for knee osteoporosis. It's from a very high volume center, and as we've already discussed, the outcomes and the follow-up are excellent, and the retention is really, I think, remarkable. But Matt, what do you feel are the key findings of the work? I suppose in the context of any potential limitations of the data.
Yeah, my key finding take home, and what I say is, when you go back to your practice and you see the next patient with primary secondary osteonecrosis who has joint degeneration that's failed conservative management, you should not be hesitant to proceed with total knee arthroplasty if they fail conservative management. The radiograph showed joint degeneration. In contemporary series with contemporary implants in the hands of high volume surgeons, these patients do extremely well, have significant improvement in the clinical outcomes, and have 10 years survivorship free of aseptic loosening that competes with any other routine osteoarthritis. So I do not think that this is a contraindication for total knee arthroplasty.
Yeah.
The second thing, and I think, traditionally surgeons have been apprehensive on proceeding with total knee arthroplasty in this subset of patients, concerned about aseptic loosening. The second thing I always say, and I learned from this paper in looking at the data, writing the paper, editing the paper, is that if you think you need adjuvant fixation with a cemented stem, proceed with that. In contemporary implant design, it is minimal and incremental time. There's minimal bone that you have to remove, and it does give us the protection if there's poor bone quality for long-term implant fixation. Yeah. Finally, my kind of third take home from this is be cognizant about manipulation under anesthesia and the limited motion that these patients may have post-operatively. And so if you use any neoadjuvant treatments, if you want to follow these patients closer, if you want to have a lower threshold for manipulation under anesthesia, just be cognizant about it. And you should set the expectation preoperatively that this is one of the most common complications after this procedure in this subset of patients.
But that's fantastic, man. That's a really, really, really clear three messages from the data, very much supported by it as well. But if we just move on to, suppose, Matt, just briefly about a limitation, could it be argued, obviously the Mayo Clinic, it's a very high volume center, it's a very, a lot of expertise there. Could that potentially be perceived as a limitation of it in terms of, does it have to be high volume surgeons or high experienced surgeons who are doing this, do you think?
I don't think so, but we all are aware of the data on volume and complication profiles. So I think that's unrelated to this particular topic, but more related to knee arthroplasty in a bigger perspective. So clearly, if there's any concern or you're uncomfortable with having to incrementally use additional fixation, then maybe the patient should be referred. I think, in this series, it spanned a time period that included a number of surgeons from the Mayo Clinic. And so that in itself almost takes care, even though it's from a high volume institution with the majority of surgeons being high volume, we do have a number of surgeons that participated in this series. So it mitigates that with a heterogeneous number of surgeons who participated in care of these patients. Sure.
No, that makes sense. And I suppose as well, what you're sort of saying is that the condition itself doesn't preclude people from doing it as long as their volume is reasonable. Is it correct? With that? Yeah, absolutely.
Yep.
So in terms of looking at the previous literature then, how do you feel that your results fit into that, Matt? And particularly with, I suppose, regard we've alluded to already in terms of implant design, and as we've already said, comparing it to routine TKA for osteoarthritis?
Well, this series seems to indicate it better than historical series. There are a couple of more recent series that have shown contemporary results have done much better in patients with knee osteonecrosis. But this is, I think, the largest that I'm aware of, unless anything's changed recently, with this length of follow-up and this completeness of follow-up, showing with contemporary implant designs, contemporary surgical techniques, and contemporary perioperative management of these patients, the results compete with knee osteoarthritis. And it does seem to be better in regards to survivorship, free of the numerous endpoints I noted before, better in regards to clinical outcomes. And, to date, knock on wood, our radiographic evidence of loosening is 0 in those who aren't revised. So great results in regards to the radiographic parameters. So we are moving in the right direction compared to historical series.
Absolutely. And in terms of, if we just briefly go back to what we alluded to before, how does your study compare in terms of to previous data? What we discussed earlier about the indication for it, whether it's primary or secondary osteonecrosis, because there is a slight difference there, isn't there?
Yeah, previous series had shown a difference between primary and secondary osteonecrosis, and I thought that would be the same for a variety of reasons. That if it was primary osteonecrosis, there was more of a pathologic process. If it was secondary, it might be temporal, related to the external environmental factor that, for instance, corticosteroids that might have been used for A, B, or C other pathology. And in this series, throughout the entire analysis, we found absolutely no difference whether it was primary, secondary, and the cause of secondary. So in my mind, in contemporary practice, I lump them together when I'm treating them. Yeah. And I look for the same indications. You failed conservative management and you have radiographic evidence of joint degeneration. In my mind, regardless of primary, secondary, I treat you the same. You have the same potential outcomes in regards to the parameters we've discussed.
That's brilliant, Matt. That's great. Well, Matt, I think that's actually all we have time for. We're running out of time there, but thank you so much for joining us, Matt, and congratulations on an excellent study. That is without doubt a real invaluable addition to the literature in this area. So thanks for joining us, Matt.
Yeah, thank you very much, Andrew. Greatly appreciate it.
Not at all. And to our listeners, we do hope you've enjoyed joining us, and we encourage you to share your thoughts and comments through Twitter, Facebook, and alike, and feel free to post a tweet about anything we've discussed here today. And thanks again for joining us.